there is this very um, interesting bit of diary investigations that I was doing. There was somebody had published some diaries of a 19th century physician who was talking about his hands as his diagnostic tool, but also, how he connects to his patient. And now, as we were just saying, now there's all this, you know, how could it be that this could be the case that, there's this idea of a therapeutic alliance, which is fundamental to patient outcome,
Yeah.
which is fostered through, on the one hand, synchrony and interpersonal synchrony, and specifically fostered through touch. And there's 200 and a bit years between these diary entries and these, most recent works in which Carl Friston and McParlin and others have sort of said, you know, touch and synchrony is important for therapeutic outcomes.
Yeah.
And yet we've had to wait until this to this to come to the top for us to even have discussions like the one we're having now. Um, so if we've known for so long that touch is important, that interpersonal connection is so important, why, in your opinion, do you think we've lost it in many ways in Western medicine? Or maybe you think we haven't.
No, I definitely think we lost it. So, I mean, I've been in China a little bit like more recently, and I think it's a different approach there, different techniques people use. I think it's more part of this. And I think maybe I would suspect there is like an anti-correlation between the kind of development of more technology we use in medicine and, anti-correlated with human touch. So I would kind of strongly suggest that there is a correlation. And the other aspect, I think, is the more and more medicine becomes a science and gets scientific, at least at the outside. A lot of the stuff we do is actually not that scientific, but it kind of appears to be scientific. And I think there might also be like a demand from the patients, basically from the other side, kind of get state of the art, machine-like treatment. And I think people might even expect human touch a little bit less than before. So a good doctor, gets you quickly an MRI appointment and puts some needles in you and injects some cortisone, also some touch involved, obviously. But I don't think, if you're a patient, you go to see a doctor and the guy is only touching you, I think people might even be disappointed. So, yeah, so I think overall, I think it's technology. And I think it's also not taught anywhere in medical school. I think it's more like the opposite. I think the more you can reduce the kind of the interaction between the physician and patient, I think it's actually incentivized to do it this way.
So I think that there's so much in what you said. So I'm going to try and unpick it a little bit and also relate what you said to a conversation I had yesterday with a fellow physician. She trained as a massage therapist first and then as a doctor, and now has created a separate practice besides her clinic
Mhm.
hours in which she does touch therapy. And she also mentioned technology as potentially being one of the catalysts for this big change. Um, what she hadn't mentioned is this change in expectation on the part of the patient, which I find very interesting. But I'll just pick up first on the technology. So again, going back to these diary entries where he talks about his diagnostic tools, his technology being his hands. And I mentioned this in my interview yesterday that I was about to deliver my second child, and this Ukrainian OBGYN managed to actually estimate the weight of the child in grams better than the high resolution ultrasound. And I think that there's this interesting point here to be made between, on the one hand, these expectations, both of the doctors, but as you mentioned, also the patients, that technology will get us a better answer. But in fact, here's one, end of one data, but where we see this time and time and again that our hands are actually super sensors.
Yeah.
And we can pick up on not just one thing, but a multitude of things because of the kinds of receptors we have in our hands and the learned experience. Talk about large language models, the amount of data that these
Yeah.
hands have processed over time. So I sort of want to get your opinion on, whether this is a false trust in technology on the one hand, and not only because it can't do the job of the hands in many ways, in diagnosing, but that we're also missing out on the other function that our hands provide. And so I think, do you think that there's this false trust in technology on the part of the patient and potentially the clinician? And then I'm going to pick up on your third point, which was on education. And I'll bring in something that Michaela mentioned yesterday, which was that when she did her first blood draw in her fifth semester, the first time she ever touched a human, it took 2.5 years before she touched a patient.
Yeah, we do corpses first.
Yeah, it makes much more sense. She was saying, well, how do I touch them before I take the blood? And do
Yeah.
I do it before, or do I do it without the gloves when I, you know, greet them and meet them? Or do I have the gloves on all the time? So this idea of education was very prominent in our discussion. So I'd like to first ask you about the trust in technology, and then ask you to say a bit more about what you meant about education.
Yeah. So to the first point, I think there's an increasing trust in technology. I think this is actually something we see right now with the large language models and or like AI revolution in medicine. I think it will get more and more. You see it already in radiology, where you rather trust the computer program to actually kind of measure stuff as compared to a human who is kind of clicking on the mouse. So I think there's definitely like a kind of degrading. I mean, no, not a degrading, increasing trust in
But
technology.
a degrading in human, right?
Exactly. So, yeah, so I think it's probably exactly it's both. And I mean, with your example, I think you're right. But I think back in the days, at least as far as I imagine, the doctor, the physician, I think was more than just a physician. I think was like a respected person. Maybe he was or she was a healer as well. So I think there was a lot of more like knowledge and skills, basically, concentrated into one person. What we do right now is we kind of what is the English with compartmentalize kind of our skills. I mean, there might be a person who's taking the blood. Then there is the lab who's analyzing this. Then there is the MRI, which is a machine, and there is another doctor who is, reading the MRI and the pictures, and then it comes back to me. And at some point, I might integrate this, but that's not all my skill. That's all of my knowledge. It's more like a teamwork thing. So I think that's one aspect. That the whole like job as a physician is not very holistic, but it's actually like fragmented into different skills. Some of them you might kind of comfy to do yourself. Some of them you kind of just externalize. So I think that's one aspect. Then this whole like n equals 1 and actually touch or using your hands might even be better. I think it's probably true in some cases. I think the whole promise of technology and science and medicine is basically to increase the average outcome. For a single person, it might be better to go to, the trusted person, who can use his or her hands to estimate stuff, to heal. You might feel comfy, but not everybody is as good as this one person, or might not be as much trained or not much comfy to only use the hands. And I think the whole idea is kind of using technology, kind of, again, externalizing the dependence of the knowledge and thus the dependence on the doctor. So the average level of healthcare increases. And I mean, I don't have data on this, probably have to look this up, but I would suspect that's actually true because there are a lot of bad doctors as well. So I think
I
this kind
find
of
that fascinating.
evens out the individual difference, I would say.
So you mentioned a word, or you hinted at a word that we picked up on yesterday with Michaela, outsourcing.
Yeah.
And and you called it compartmentalization or specialization. And I'm just going to pick up on those two words very quickly because I'd love to hear what you have to say if we take those two things together and think about what touch really does, which is give us a big picture, you know, view on things. Because I think of the multitude of receptors, because of the functions of touch. So very much inherent to touch is picking up on lots of information,
Yeah.
bringing it together, synthesizing, and communicating. And I wonder if there isn't something that, first of all, here's the bright spark, the Hoffnung, right? The hope
Mhm.
is maybe there are little ways in which, even at the averaged out level, we can introduce small versions of touch interactions that don't interfere with, mainstream medical practice, which has to be efficient, right? But which would still provide some more information, more big picture thinking, and more interpersonal connectedness. even for the average.
Yeah, so I do agree. I think definitely small steps. I think one aspect is the kind of diagnostic touch, and then the other aspect is more this kind of healing touch, more like the therapeutic touch. I think these are like two different things kind of you have to consider. And I think you're definitely right that there's in one touch there's a lot of information, which this kind of multisensory integration, so it kind of gets integrated within your brain, but it also gets paired with your experience. So that's kind of sensory, and then it gets modulated or influenced by the experience, and not just the knowledge, but maybe also the personal experience you already had in your life. And especially since, I mean, not sure if I still qualify as a young doctor, probably not, like a middle age. But if you have not much experience, yeah, then it's also way harder to actually integrate um, this information. Yeah, so I think that's definitely something you kind of have to learn. I don't think that like a young resident who barely touched a person in his or her medical school is then like getting the same amount of information from a human touch than someone who has more experience with this. So I think there's a learning trajectory, I think, which is important. And maybe you can, and I think this is, I think, how medicine was done before. You had more like this kind of teacher-student relationships. So someone is kind of, teaching you, showing you, you touch first, and then you let the resident touch. And this is, I think, how learning happened back then. Now learning is well, first of all, more in books and then more online. So I think there's also less, teacher-student relationship, which also, does not help to implement touch.
Or maybe
Because
you can speak to that with a little bit more detail in your experience. Um, First as a medical trainee, when you were learning, were you of the old school, or were you already seeing this depersonalization, this less touch? And if it was the latter, if you felt already then that there was less interpersonal interaction, what has made you become the doctor you are today, and we're having this discussion because you believe that touch should be there.
yeah, I do agree. I think in medical school, at least in Germany, I think the whole approach is, and I had debates about this also with the chair of several departments already, is basically to educate physicians, but also researchers. So it's kind of integrated, which I don't think it's my opinion. I think medical schools should first and foremost kind of, produce or educate good doctors and not necessarily good researchers, but it's still kind of the ambition to have researchers as well. And I think we definitely have a trend. And I think, again, for the average, that's definitely a good thing for evidence-based medicine. And touch is at least perceived. It's not very much evidence-based. I think it's perceived. It's like uncontrollable, subjective. So and therefore it's not taught in school, and people rely on the kind of hard facts, quantitative facts, meta-analyses, medication. So I think yeah, definitely. So it's not taught. I think it's more like the opposite. So you learn about personal hygiene. You already mentioned the gloves people wear all the time. Yeah, so I think it's actually de-incentivized basically to touch a person.
And so you that was your experience as a student as well.
Yeah, I think it's more like looking back now with the knowledge I have now. I think I would kind of, phrase it this way. I think during medical school, obviously with less experience, you kind
You
of do
didn't
what you're
know.
told to do. So I think you don't have the kind of the big scope or the big picture there. But I think looking back, it definitely at least it did not incentivize touch. And I think it's more the opposite.
So
Although
what
there are a lot of classes and courses, and they're all kind of called like, with the Anglicism hands-on. So there's a lot of hands-on stuff, and that's also what the students actually demand. So a lot of artificial bodies are lying around. So there are specific emergency labs where you kind of try CPR on robots basically and all this. And people also try to get students quicker in the hospital. So there's definitely, I think, this kind of it's on the one hand it gets more scientific and more like there are more machineries involved. On the other hand, the students are also bored by just reading like papers or just clicking something online. They actually want to be with patients. The question is just and I think you sent me the question before, what is actually, social touch? What is like touch in medicine? And what is this kind of healing touch? And I think that there might be more touch in medicine in medical school right now because it's demanded by the students, but that is not necessarily like a healing touch. It's more like you put needles into people or something. So which is still a touch, but it's a different thing, and it only serves the purpose to basically gather more data.
Okay, so I'm going to I'll come back to my previous question, which was what changed. Um, so you noticed at some point, you said maybe only in hindsight, that the education you received almost disintensified touch. And we heard this yesterday. I'm going to repeat it because it gave me Gänsehaut. Like I really got chills. She said that this first time she took blood, she asked about whether she should have her gloves on.
Yeah.
And she said, and she told me that she was told that bodies are ekelhaft, that they are disgusting.
Yeah.
I want to have your response to that. Like, did you have something similar? Did you also have the touch disincentivized to that point that they are, a source of infection?
Yeah, so I think there's a lot of Betriebssicherheit, so which is kind of important, at least kind of probably in all hospitals, but in Germany in particular. So I think you are heavily advised to have gloves on all the time. I think I also got them, but that's very individual. I think I remember being in dermatology, which is, a kind of department where you get a lot of rashes and, it just looks weird and looks very infectious, but it's actually most of the time it's not. And the dermatologist, actually, when I kind of, had rounds there as a student, they basically rarely use gloves. So I think that's for me was a little bit like, now that I look back and remember kind of a little bit turning points, I was thinking, oh, even the dermatologists who kind of touch all this very gross, skin changes and all this, and they're not afraid and they don't do this. And since then, for me, I try to reduce the amount at the time I wear gloves. So it's definitely if you take blood samples, most of the time I wear gloves, and you're supposed to for safety reasons. But other than that, I rarely wear gloves. For example, I do the ECT treatment sometimes here in the clinic, so in electroconvulsive therapy. It's in the anesthesiology department, so it looks very medical. It's a medical environment. There's an anesthesiologist. They have their kind of blue uniform. They look like they come from a surgery room, and they all have gloves. I basically don't wear gloves. So I go in like I look right now. I have my gloves. I want to give the patient the kind of most normal kind of impression. I'm basically just rubbing the skin a little bit, put some tapes there. I don't need gloves for that. I'm not injecting anything. And I think that's already like a difference. Just, I try to, I still do an invasive therapy basically, but I don't need the gloves. And I think that's already shows the difference between me in this role as a psychiatrist in this very moment and the anesthesiologist who put needles in you and, you give you oxygen and they have gloves. So it's already
I
different.
find this very interesting. So in our research, we work on interpersonal distance, this bubble we keep between ourselves and others. And yesterday I'd heard about the fear, this disincentivization that you talked about, this fear that's engendered in you as a training clinician, that you should be scared of your patients and the diseases they may give you. And I think what you just added to that is this idea that you also want to reduce the fear in your patients. You want them to feel comfortable. And all of this is to, in theory, reduce that distance between you and them.
Yeah, but yeah, I do agree. So I think it's a conscious decision. So I think the different aspects, obviously. So there's this kind of, oh, there is this infectious disease and I need to be, safe. And especially in psychiatry, a lot of people have hepatitis, they have HIV. So you should definitely wear gloves if you do specific medical procedures. But not touching people also kind of implicitly builds a barrier. You are not kind of emotionally engaged. So it's not just, you kind of avoid getting infected, but you also kind of avoid getting infected emotionally. And this is what a lot of doctors prefer to do because they have a very high workload. They have a lot of patients. For example, I did 1 year of neurology rotation, which was very intense. And all the time I had 10 patients and they change basically every other day. I get a new patient for each patient. So there's a lot of rotation. And if you get emotionally involved and touching people very often involves this aspect a little bit more than just putting needles in people, you also kind of protect yourself from this kind of getting emotionally overburdened. I think this is also something what a lot of physicians actually prefer to do, so they can go home and they don't take the work with them and they don't get too involved, too emotionally involved. I think that's also something what a lot of doctors do just to protect themselves emotionally. And this might also be a reason that touch is not so much kind of used.
I'm going to refer again to this interview from yesterday because I think there's such a really interesting. I wish you guys could both be in the same room. Maybe we do that next. She was talking about the fact that she has opened this additional practice where she does touch therapy based on her massage background because she felt a lacking, she felt unfulfilled, and she felt drained because she couldn't, catch the emotion, couldn't connect with her patients because it was this high time pressure, high turnover. And so she almost felt, well, I wouldn't say it's the opposite because I can completely understand like capacity limits. but that there is also this yin to this yang, that if you don't connect, you also don't derive the benefit of that interpersonal connection. I wonder if you have felt this, because there's clearly a cost to touch.
Yeah.
And we heard this at the most recent ISAT meeting, this International Association for the Study of Touch. We talked about the cost of touch. But there's also a gain from paying that price. And so I wonder if you could speak to that, to what you gain from committing your energy and becoming close to your patients.
Yeah, so I mean, I mean, in psychiatry it's a little bit special because normally we don't touch much. So we are basically one of the disciplines who's, apart from, I don't know, microbiology or something, who's basically not supposed to touch the patient. I mean, we might do a physical examination in the beginning, but otherwise we only talk. And the interesting thing is we talk about a lot of very private things, and I think it's, in that sense it's way more intimate to kind of have a kind of psychiatric doctor speaking with his or her the client, than compared to actually having a, I don't know, major surgery in your stomach or something. So it's actually, people kind of report that it's already very kind of intense emotionally. Yeah, so I think so it's already a very intense relationship you kind of have with your psychiatrist. And then I think people are very careful, and same with me, to actually add the physical layer of touch as well. Because again, and that's also very special in psychiatry, because we have this kind of disbalance between the knowledge of the kind of psychiatrist and the client. Touch is vice versa, so both kind of get information about the other. But the cognitive therapy we do before is heavily asymmetric. So, I mean, I know a lot about my patient. The patient barely knows nothing about me. And so the touch can be somewhat an equalizer, but it might also just add even more to this disbalance, which you don't want that much in therapy. Also, people are very vulnerable. So I'm extremely, extremely careful to use touch in my kind of psychiatric kind of practice. On the other hand, I clearly see the benefit. You ask for benefits. I strongly believe that, I mean, mental disorders are like system disorders. We already spoke about this, like multiple layers of, which kind of interact with each other. And obviously the human connection between therapist and client is important. And there are a lot of, I mean, in research, we say non-specific effects, because probably just hard to measure. They're definitely there. And touch is one of those. And I think, again, a good doctor should harness all specific and all non-specific effects he or she can use to be a good doctor, and touch is one of them. So I definitely see a benefit that I think, especially in psychiatry, because of the disbalance of the relationship, you have to be very, very careful.
So I'm going to piggyback on that asymmetry that you talked about, because I find this very interesting. I'm going to give you a little bit of background, is that we are working in our lab on this idea of vulnerability, trust, and together with Asaf Bachrach, we are talking about the different variations of these combinations. You can have a patient-patient situation in which two people are vulnerable together.
Yeah.
You can have a patient-agent in which the agent props up the patient. And that would be the more traditional clinical scenario, where a doctor has expertise, the patient is vulnerable and sick, and the patient has to look up and trust this doctor. And then there are very rare occasions, but we look for them where both people are agents and neither is vulnerable, but we still choose to be with each other. And I felt like what you were saying is that touch is a way of assessing that relationship, first of all, that asymmetry, and then potentially compensating. But you said that sometimes it can go the wrong way. So I'd be curious if you could expand a bit on that, because I think that vulnerability, you've talked about the vulnerability of the clinician, right? Vulnerable to disease, vulnerable to the cognitive and emotional load.
Yeah.
If you could speak to this vulnerability, to this hierarchy, to this asymmetry, I think I would love to hear more about how you feel you use your knowledge of that to determine when to touch and when not to touch.
Exactly, but I think that's also like an intrinsic process. Most of this is probably kind of unconscious. Obviously, there are specific kind of, the kind of no-go areas where I would never touch. So, I mean, as a male, I'm obviously more careful touching females. I think that's a huge thing for me. I'm way more careful. Age difference or age in general plays a big role in my decision to touch someone or not. So I touch older people a little bit more kind of freely or more easily, I think, without much hesitation. And then you, I mean, you kind of, I think you differentiate a little bit between like social touch and then this kind of more like healing touch. Sometimes I do ask for permission beforehand. Sometimes, for example, yesterday I had a patient, she is, I don't know, around like 50 or something, and we actually had to kind of put her in restraint because she wouldn't eat and wouldn't drink. So we have to give her medication. I was sitting next to her for like an hour, and I was holding her hand because she was afraid that, you know, the infusion she got, which it was just water because she wasn't drinking, but she was very much afraid that this would be poisoned or there would be something in it. So yeah, I was sitting there and basically kind of putting my hand next to her hand, kind of offering, you know, and she grabbed a little bit, and then I did this for a moment, and you know, and then I let go again. So I think that's one of the kind of occasions where you kind of offer it a little bit implicitly. But on the other hand, I mean, this she was restrained, she was fixated on the bed. She was so incredible vulnerable in this moment, and I had incredible power over her. I could decide what fluid goes into her body. I could basically decide how much she can move. And then, and that's also a problem in psychiatry because we use touch not just in a healing beneficial way or like a supportive way like I tried like afterwards, but we actually also use touch to kind of press people on the bed and restrain them. So especially in my kind of on this acute ward, touch has both, so you have to be even more careful because a lot of patients are actually getting traumatized by being touched, yeah, against their will with force. And you know, I kind of in my daily practice, I kind of live between those kind of two extremes. I mean, you know, kind of you hug someone if someone is crying, or you hold hands if someone is crying, but you also in some occasions basically have to touch people and put them on the bed. And I think that's kind of this scale of touch I kind of have to operate, and then I kind of have to decide if there's something I want to do or don't want to do. And interestingly,
I've never heard that. I think that was extremely powerful. I think that's we need to write a paper on this. I'm just putting
yeah.
that on the side there. But I had never considered the gamut, the spectrum of touch that you
Yeah,
as a
and the interesting
psychiatrist.
thing, like legally, the kind of pressing the patient down, that's actually I'm allowed by law. So you know, the judge decided I'm allowed to do this, so that's written down. And that's basically the legal aspect of this, touching my patient, you know, giving her the hand or you know whatever, hugging her. I mean, not this person in this vulnerable situation, obviously, you know, but in general, that's actually not necessarily covered by the law. So, you know, since my patients, you know, just imagine I would hug someone or kind of offer a hug or something and it's uncomfortable for patients, and they might actually sue me. I just kind of call the police. So there's something which happens on my ward quite often, not because people touch, but people tend to call the police very often. So it's just interesting that actually this restrainment is actually kind of covered on legally, and the kind of the more like human and the social touch is actually not really covered by anything. So that's also interesting.
I'm really sorry I interrupted your flow, but it was such a powerful comparison. It needed to sit in the air for a bit because I think, you know, people talk a lot about good and bad touch, but usually it's just that there's a subjective way in which it's perceived. But I think it's quite objectively clear that one is a forceful touch and one is at least intended as a soothing touch. And I don't think we hear about that at all.
Yeah, and it traumatizes people. So I mean, good practice is that you kind of explain before what's going to happen, so you already kind of have the expectation. So normally I don't touch patients. So this patient I didn't touch before. I went into the room, tried to give her the medication, tried for half an hour. She wouldn't talk with me. She was afraid. She was just crying. She was screaming. You know, and I told her, you know, if you can't take the medication, I'm sorry. I'm your doctor. I'm responsible for your health. You really have to take this. You know, the judge decided, and if you cannot take this pill right now, kind of have to go to the bed. I have to put you on the bed. I have to restrain you and give you an infusion. So I kind of, you know, I kind of contextualize this, but nevertheless, it's super traumatic. And after this kind of, you know, situation, we normally, I did this with her as well. We kind of have like another round of conversation with her, basically asking how she perceived this, how, you know, at least you try. To kind of, you know, have a little bit of, you know, kind of conversation afterwards. But people get traumatized by this rightfully. It's true. And you know, not just patients get traumatized, I get also traumatized, yeah, because I don't like to touch people this way. And that's a problem as well.
I stopped your flow. Do you remember what you were going to say after that?
No, I forgot.
That's all right.
Sorry,
So we were
I forgot.
talking.
I just think, I think that's the kind of the scale of touch we kind of do on my ward, and yeah, again, it goes from hugging a patient when they are said to restraining people. I think it's just very hard to decide when to do what.
So I think that was so useful because I really don't think I've read about that anywhere. And what I really liked is right at the end you also mentioned that touch is always relational, and so it has an effect not only on the patient, but it has an effect on you. So I think I think I think I'd love to come back to that because I've mentioned it already once before. This is the second time. We'll go through it a third time because I think it's important to think about what touch means to the patient and what it means to the physician, to the clinician. I think it's I think we both here today because we agree that we need to have more discussions about touch. I think what you've added to this is that it's very nuanced, that it's not a straightforward thing of just add more touch.
Yeah,
So
I think
maybe
in
you
the
could
context
speak
of this
to,
kind of relationship, I think obviously, if I use my power to touch someone, to restrain someone, this kind of obviously kind of, tilts the disbalance like to its maximum. And then sometimes you can use touch to kind of get more equal. I was sitting next to her and I thought like touching her hand, holding her hand. I thought it was kind of going back a little bit to probably not equal, but a little bit. I think I used it kind of to reduce the difference between us in terms of, kind of power or kind of hierarchy or something. So in that sense, I kind of use touch there. But
I really like that. I think that's a really useful way to sort of put a closing parenthesis on that concept of patient agent hierarchy and asymmetry. And I really like this idea that there can be an imbalance, which is in fact amplified through forceful touch,
yeah,
but that depending on willingness, you can then use touch and different type of touch to reduce the imbalance. And I think that there's something in there. There's something really interesting there because I think, we use it in our daily relationships as well, right? We'll use a more forceful handshake or a soothing
yeah.
hand to the shoulder. We need to move away from this idea that touch is unitary in its form or its function. And I think you're giving a really good representation of the different forms and functions of touch within your practice. Are there any other kinds of, just to sort of see if I've missed any, but are there any other kinds of touch that you use? You've mentioned, healing touch. You've mentioned touch where you've had to have an intervention, like put a needle into someone. You've talked about forceful touch withhold aggression or to stabilize them. You've talked about soothing touch to calm them down. Are there any other types of touch that you can think of? Obviously, if you can't, it's also fine. But it's fascinating to hear about the different kinds of touch that you encounter.
Yeah, so I'm not 100% sure about the definition of healing touch. So I think if the definition kind of refers to the intention to heal someone or to improve something by touch, I'm not sure how much I use healing touch. So I definitely use more, I think, the social touch aspect, kind of just to foster human relationship, understanding. Sometimes, as kind of a touch might, kind of give you more information than just the words can give you. Some people are not able to speak. So we have patients with catatonia, so they basically don't speak. So sometimes if you hold their hand or you kind of have their arm or something, that helps. So this is something words cannot achieve. We have a lot of people who are kind of delusional. Yeah. So when you talk to them, whatever you talk, you're not sure if your what you try to say is actually perceived in the way. I'm actually fairly sure it's rarely perceived the way I want to do it. So I think it's a common problem in human anyway, the information transfer via language. But I think that problem is even amplified, especially in schizophrenia or also people who are intoxicated with drugs. So I think their touch is kind of a shortcut kind of to information. I think that's also something touch can be used, and that includes the kind of medical touch, which also gives you information. If someone is sweating or there's fever, you kind of touch the pulse or something. Yeah, but there's definitely also this kind of calming, soothing touch I use, especially more in elderly people, as I said before. Also use it like before the procedure. I think that's also something I use. But I think the healing touch per se, so really touching someone to heal, I would say I rarely use. And I think you asked me, I think you sent me the list before, how is kind of feeling touch perceived. And I still think, for me, the word sounds awfully esoteric, non-scientific, and I have to think more about this kind of German word Wunderheiler. So, someone who is kind of basically performing magic, and I think that's kind of the connotation. Might be different in different cultural kind of backgrounds. I have a lot of people who are Muslims on my ward as well, and it already seems, I mean, not an expert on that, but it seems that their touch is also a little bit differently perceived, especially also among men, which is interesting. So I think there's way more touching, there's way more hugging, on the shoulder, this is common. So I think I use this quite a lot. And sometimes the patient initiates, but you still, I mean, have to be, I think it's still a thing you, as a doctor, because of the hierarchy there or the disbalance, you still have to be in control. Who's touching when? So even if the patient is touching me, sometimes I say, no, sorry, I feel uncomfy. I don't want you, to touch me, and vice versa as well. So I think, again, it's I'm not even sure how to describe when the moments arise, I decide to touch, because very often it's not planned. It's not, it's more like it's a feeling. Yeah. So I would be interested in how do I decide when I touch, basically. So I think that's interesting.
I totally agree. I think we mentioned that in Montpellier. That'd be wonderful to try and identify these moments, right? What catalyzes them, and then what is the effect afterwards. I wanted to ask you about this impulse because I heard yesterday that this other physician had an impulse. She needed to touch her patients. I'd like to think, I mean, it sort of goes in the direction of what you're saying. You'd like to understand why it is that you do so when you do so. Or do you think that there is, and you talked about cultural differences, so there's a layer there as well, that there's individual and cultural nuances there. But do you think that it would be that there is a more natural way in which we could practice medicine, in which doctors could reach out and touch if they felt they needed to, given consent, obviously, and that patients equally could ask for it if they needed it? Do you think that that would be a more natural way? Follow these impulses within reason, obviously, hygiene, consent, and so on.
Yeah, I think, I mean, since touch is also, a continuum, I think there's a huge difference between different kinds of touching. I think, I think going from a handshake, which a lot of doctors actually don't give patients. So I try to, every time I see someone, I give handshake, sometimes, get the shoulder touched as well. So I think I try to do this I do like, on purpose, basically. So I think I try to maximize my touch there. I think otherwise, I mean, obviously it's good to have consent, but I still think I'm not sure how much you want to rely on the individual doctor or the individual patient to kind of decide what is a good touch or what is a bad touch. Again, for me, I could say, oh yeah, I have the feeling I have it under control, but there are a lot of, because of this disbalance, this hierarchy, I think there are also a lot of danger actually in touching, and especially in psychiatry where clients are so vulnerable. And I sadly know a lot of examples where this actually went very, very wrong. So I think that there should still be clear boundaries what good
And is that
touch
by
is.
body? Is that by body zone? Is it by gender? What do you
Exactly.
think are how do we create a structure in the perfect world? How do we create a structure in which touch is used when it's useful, but limited so that it doesn't become dangerous?
Exactly. So yeah, for me, I mean, basically the only touch I use is I mean on the hand. So I think that's something I obviously use and occasionally, but that's more rare, kind of to hug someone. So I think these are basically the two kind of categories of touches I use, apart from the medical examination. If someone is complaining about the legs, whatever, I normally just kneel down and touch their legs. I mean, I'm not an expert, but I think still touching, paying attention there is important. That's definitely like more like the medical touch, which I also again try to maximize. But otherwise, I'm in my kind of behavior portfolio, I'm fairly much restricted to those two types of touches. And I'm actually not sure what other touch I could kind of incorporate into kind of at least my work. Obviously, if you're like a pain therapist, for example, my dad used to be a pain therapist. Pain therapy involves a lot of touching. Yeah? There's massage, you put some tapes on someone, you inject someone. If you do acupuncture, for example, which he did, there's a lot of touching involved. So I think these are different procedures. In psychiatry, it's a little bit harder because there's basically no medical excuse kind of to co-touch people. Yeah. So in my case, I basically would need to decide, but just given that a patient would come and ask, hey, can I hug you? I think my first response most of the time would be no. Because that's kind of the reflex I'm kind of trained, because it kind of loosens the boundary between us two. It kind of might shake my position as the almighty doctor and make us more equal, maybe. And I don't want this, maybe. Yeah, it kind of gives power. As if the patient asks or the client asks, it might give power back there. And then in psychotherapy, I do less psychotherapy right now on this intensive care ward because people are just not as fit as like on a different ward. But a lot of people fall in love with the therapist. So this is something quite often, it happens quite often. And then obviously the desire for touch also arises. And then I think this is also something you kind of hopefully learn within psychotherapy education, how to deal with this desire.
So I'm going to pick up
Sorry, too many
on the
things.
types of touch that you talked about, because I find that the first thing that came to my mind is that both handshakes and hugs are quite reciprocal in nature. Obviously, you can hug someone and they don't hug you back,
Yeah,
or you can shake somebody's hand and they can sort of go limp. But there is at least this idea that we have to both decide
yeah.
together. Whereas I might be completely wrong in this, but it seems to me that most of the other touches, it's harder to be reciprocal.
Yeah.
I'm curious. I'm sort of sorry. I'm just thinking aloud. I'm trying to figure out, is that because used sparingly, these are ways in which. So I had assumed that the discussion we would have is that touch would be used as a way to sort of to reconnect, to bring somebody back when you're having a discussion with them, or it's like it's momentary ways of reconnecting deeply, to understand, to communicate. You've mentioned various functions. But I'm wondering also now whether that's even more the case because of the kinds of touch that you're using, and that it has to come from both parties.
Yeah, I think it's a shift of your role. So I think now in kind of medical education, we basically learn that a physician has like multiple roles. So there's the one of, I don't know, a doctor, then you're a teacher, then you're a leader, then you are a scientist or whatever. You have different roles. And I think hugging someone or, really, really not, maybe not shaking it, but like holding hands, it changes your role for a moment. So I think you're not within one of the kind of established categories. I don't think there is a role for
Friend, or yeah, or
yeah for
a
this
peer, or
being the person who is touching and who is being touched at the same time. I think you're more like maybe more closer to a friend for a
yeah.
moment at least. Probably not the same concept of like really having a friend or um, yeah. Basically, I think basically you just become a human again. Yeah, so you kind of give up your role. You kind of all kind of build up during medical school and and the training grounds and all this. We kind of build up this kind of role, and then for one moment you kind of decide if you kind of kind of give in this interaction. I think it's you kind of offer yourself as someone who is in this moment not a doctor, who is not a leader, who is not a scientist, who is just a regular human. I think that's kind of giving up this role. I think that's kind of important.
I find that fascinating because I would never have come to that myself. It makes perfect sense. But in a recent paper we've been trying to write, we've been talking about the handshake, especially in a political
Mm.
scenario, where there the handshake and the nature of the handshake is very much used to define roles and define power structures. So I find that there's this really interesting clash between what I had in my mind of these handshakes and what they represent. And here you're saying that in fact they break down all these, you take all your hats off. You just for that moment at least, you're on the same. And I find that it is obviously what a handshake is supposed to do, right? But then it's been perverted in my head seeing these politicians shake hands as being something quite different. So I find this fascinating. I think it's really all wound up in this idea of the asymmetry of the hierarchy
Yeah.
of these roles that you have to play. Fascinating. That's a really great, like, again, parenthesis to that theme. So I have lots to think about there. In the last few minutes, I wonder if you have any questions or thoughts that we haven't talked about and that you feel you would have liked to have talked about on the topic of touch in your specific practice or touch in medicine more generally?
Yeah, I mean, I really want to ask you about the definition of like healing touch because you know it's kind of used. I looked it up. I think a few years ago when I was in Chapel Hill, I actually found a book on the street. I think it was actually named Healing Touch, and it was like, but it was more like I think it was written in San Francisco, like in the 70s or something. So there was a
I've
lot
read
about
it.
you know like Buddhism and you know and open your chakra gates and all this. So this is also where my kind of more like esoteric association comes from. Then there's obviously this whole like kind of branch of Heilpraktiker in Germany, which is so super fascinating that we have this kind of, you know, besides the radical, normal, you know, kind of more or less evidence-based medicine, we have this whole system of Heilpraktiker, and I think they actually all work with touch. So I think it's even more important there. So I'm just asking you about how would you define healing touch? Is there a definition?
There is not. This is the problem, is that in fact in English, in healing, the word healing or even therapeutic touch has a terrible connotation, not just esoteric, but a bad
Yeah.
connotation, at least within in the clinical, the Western clinical uh, domain, for the very reasons you've already spelled out. You
Mm.
know, it's sort of a there was an esoteric practice of the 70s. And yet we started our conversation today saying that there are at least thousands of years of healing touch-based practices outside of the West that we now know more about. You mentioned acupuncture today, um, which maybe isn't a skin-to-skin touch practice in all cases,
Yeah.
but it's definitely, to my mind, um, on the somatoform, and it is a practice in which you try to heal through some kind of pressure.
Yeah.
I think that, to my mind, we need a definition that allows us to progress. And what I mean by that is I feel that we have these little bastions, these little spaces in which people see the benefit of touch, or where people are craving touch. And so the conversation I had yesterday was with somebody who in her clinical practice has people come to her and saying, I'm missing having contact with my physician, physical contact with my physician. In her practice, where she practices what she says is Berührungsmedizin,
Yeah.
she uses touch to very much more in the massage-like style.
Mhm.
So on the one hand, she's using it to understand the body that's underneath her hands, but also to try and relieve tension or to
Mhm.
heal pain. To my mind, we can either have a super broad category and just say that any touch which is used specifically to target pain or injury or disease or a disorder should be seen as healing touch. It's trying to, it's an intervention through touch, with the object of healing. But then you mentioned these interventions which will have an indirect effect on their well-being, like giving them a drug through a needle. Um, and so you have this problem of how direct that effect has to be. So I sort of go back and forwards with the idea that maybe the only way to move forward, to make progress, is to create an openness to the idea that some touch can have direct effects on health, whether that's in massage or acupressure or physiotherapy.
Yeah.
Some physiotherapy manipulations are very much touch-based. Um, Maybe we just have to allow for there to be an openness to knowing that these kinds of practices exist, that they have benefits, and then to provide data for those who need it. So I think you mentioned, oh, it's only now that we know that there's this data that we can accept that this is potentially a useful avenue. And I think I'm very much on that page. There is no definition, to answer your question more succinctly. There is no definition. The definitions we have are extremely weak because they can't possibly capture the whole breadth of it. The one major issue, as I mentioned, is the directness of the effect. Right? In science, we'd like it to be like in pharmacology. I put this drug in, it has this, it hits this
Yeah.
mechanism, it has this effect and these side effects. I don't think we'll ever have that with touch because of the way in which it's coupled to so many other things. And I think that that's probably the issue, is that we're never going to have an analogous, setup to what we have with pharmacological interventions. So I think to answer your question, I don't think there is a definition. I think the definitions that are circulating are poor, and that the main issue is the directness or the mechanism.
Yeah. Yeah, I think there are two more points I'm just kind of remembering right now when thinking about my work. I think one, because a lot of my patients are actually fairly permanently in the clinic. So some of them are there for weeks or even for months. And I mean, I think they're obviously craving human touch because they're lonely. I think that's something which is, kind of even increasing the longer you stay. It also seems some people actually kind of desensitized towards touch, so they unlearn how to kind of perceive touch. So I think some people are kind of getting more and more afraid of being touched. I think that's also something also like with regards to trauma in the past. So a lot of those kind of patients I have there have trauma involving touch in the past. So I think that's also like this duration of this, like, especially therapist client relation, which I have, that's very special, because normally you can of course see a doctor for, even if you get physiotherapy, it takes like 45 minutes, then you leave and you come back next week. My patients are there, I have patients there on my ward for 2 years. Yeah, so I think that's also something a little bit special. And the other aspect, which I see between patients, because sometimes also patients touch each other. So there's hugging there is, so that might help in some aspects. Obviously, sometimes it's unwanted, and might also be harmful. And there's also sexuality happening on the ward. Yeah, so those desires are not just gone because you're in the clinic or you take medications. So there are, one again, that there's also sexual touch on my ward, and I think that's also something which we, well, don't, how do I say,
But yeah, you would never hear that spoken about ever. And I
yeah, so
think it's
yeah,
interesting because it's almost like you describe it as this really almost anthropologically, like it's this very interesting, context in which humans experience very extreme versions of
yeah,
the normal day-to-day, need for sexual touch or loneliness or isolation or fear, but it's all amplified. And then on top of that, you're surrounded by others who are experiencing it at the same time as you. So I think it's a
exactly.
very interesting context,
Yeah, the
obviously.
environment is super special. So I mean, it kind of, for me, it's really, it's interesting because a lot of people have schizophrenia and they have delusions and hallucinations. But if you think about it, actually, the one of the wards I'm working on is basically the one where you basically can. I mean, although you're kind of locked in, so the doors are closed for most of my patients, not all of them, but they're kind of closed. But actually, you can behave fairly freely. So it's very interesting. So I mean, you're kind of locked in, but you can behave basically, unless you kind of harm other people or yourself, you can behave however you want. So everything is tolerated. So it's actually kind of, in that sense, also kind of an area of like freedom of behavior. So that's very interesting. And it's just the sexual touch, well, we don't, how do I say? So normally we don't want this on the ward because we cannot control it, obviously. And for us, it's, people are very vulnerable on the ward, and yeah, it's very often it's not clear if everybody is able to give, like, how do I say, informed consent
Potential, yeah.
for this kind of sexual touch. So that's actually a problem, and we actually try to kind of separate people then. So that's a touch which is not, although it's natural, obviously it's human, it's also understandable, but we know about this, we kind of have to do something which is not tolerated. Yeah. So that's one
Well, I mean, it
aspect.
just adds layers to our conversation on consent, but
Yeah.
also on vulnerability, right? So I think it's a really interesting case in which they're co-vulnerable together, but there might still be hierarchies between them. So where one
Yeah.
might be. So
Exactly.
I find it's fascinating because, as you say, this is quite taboo. I would never have heard of this otherwise. I don't know if I'm gonna as soon as we're finished, I'm going on to Google Scholar to see what's been written, but I'm assuming basically nothing, unfortunately.
Not sure, but it's very interesting. I think, yeah, I mean, from this conversation, especially, I think I never thought about this, discrepancy between, the touch we use to enforce basically our treatment, and then the touch who is, giving up this role and this power and just kind of make you more equal. I think that's what
I
I
think we
take.
have a paper ready to write.
Yeah, I think that's it. Yeah, it's yeah, yeah, it's good and bad.